Now we'll move to the next speaker, Professor Neil Poulter. In fact, he will discuss a very important point, a debatable one. It's should we give antihypertensive medication during night?
Thank you very much indeed, Chairman, ladies and gentlemen. Like everyone else, I'd like to start by thanking the organizers very much indeed for inviting me. I'm absolutely delighted to be here. And thanks very much. For the next 15 minutes, and I promise it will be 15 minutes, I'm going to talk about this question. Should antihypertensive medications be given at night? I'd like to think I haven't got a conflict of interest, but I have been involved with 2 of the trials, which I'll mention during my talk. So what's the rationale? Why should we give blood pressure tablets at night? 2 slides about that. And what you can see here on the left-hand side is systolic pressures, on the right-hand side, diastolic pressures, an increasing pressure giving an increase in the 5-year cardiovascular death rate. And what you see for any one level of blood pressure, take 170 systolic, as you go upwards, nighttime blood pressure systolic is a better predictor than 24 hours, than daytime, than clinic. So nighttime blood pressures are better predictors of cardiovascular events. We also know that dipping at night is the normal situation. Blood pressure goes down at night. And if you don't dip, you see on the right-hand side the impact of dippers and non-dippers. The dotted line are the non-dippers. And for those who do not dip at night, their blood pressure does not go down at night, they don't survive as well. So non-dipping conveys worse prognosis, whatever your 24-hour blood pressure readings are. And the absence of that normal pattern of dipping at night and the amount of dipping predicts your mortality amongst hypertensive patients. So if nighttime blood pressures are better predictors and dipping or lack of dipping is a bad thing, you can think people might believe we should give our tablets at night. What's the evidence to support giving the tablets at night? Well, this summarizes the evidence. The first bullet points out that we've got Spanish and Polish observational data, not trials, observational data, mainly coming from the Spanish group, MAPEC, as it was called, and the Polish group, showing the suggestion that by giving tablets at night, you got less cardiovascular events. Now, the second bullet here shows the fact that there is some nighttime dosing studies, some trials where the drugs have been given at night, and in those trials, the drugs did particularly well. It wasn't a randomized comparison, but I think most of us know the HOPE trial. That was where ramipril was given at night. The blood pressures achieved during the day was very small, but the cardiovascular benefit was big, suggesting that maybe giving it at night was better than having given it in the daytime. Cis-China and Cis-Eur also gave the drugs at night, suggesting maybe a benefit. And then we've got the Harmony trial. This was a randomized trial of people whose blood pressure was controlled and stabilized on one or more drug, and the patients were randomized to take their tablets either at daytime or nighttime. And we looked, this was carried out, we carried this out in London and in Greece, and we looked at the systolic blood pressures as the ambulatory systolic pressure as the primary endpoint. And then most recently, the HYGEIA trial, which has got everybody very excited. First of all, let's just look at the Harmony trial. As I mentioned, patients were randomized to receive their tablets either in the morning or the evening, and the primary endpoint of this relatively small trial was ambulatory systolic blood pressure, shown in red. And as you can see, for those randomized, whether you took the drugs in the morning or the evening, made no difference whatsoever to the 24-hour systolic pressure. Similarly, below that, the 24-hour diastolic pressure, whether you took the tablets in the morning or the evening made absolutely no difference. Then along came the Hygeia trial. Trial in inverted commas, I'm embarrassed to say. This was the report that got into the press. The patients read about it, they were worried, and many doctors still believe that we should perhaps take our tablets at nighttime. Well, here are the data from the Hygeia trial, and it shows on the left-hand side the benefits of total events, total cardiovascular events, then broken down by strokes, coronaries, minor events, etc. And what you see is, according to the Hygeia trial, there was something like between a 40 and 50% reduction in all these cardiovascular events associated by taking their tablets at nighttime. That seems very difficult to believe. After 40 years of looking at cardiovascular trials, I don't know anything that reduces cardiovascular events of all sorts by 40 to 50%. The story gets even less believable when you look, these are all subgroups. All the different subgroups named on the right, it doesn't matter what they are, but what you can see by the point estimates to the left, once again, 40 to 50% reduction in every subgroup in every cardiovascular event. It just doesn't seem believable. Indeed, this came out shortly afterwards, the year after Hygeia was published, an editorial which said we should disregard the data from the Hygeia trial and blood pressure medication should not be routinely given at night. Why did they say that? Well, they suggested that Hygeia was not actually a trial. It was the observational data from MAPEC. People were not randomized. There was no loss to follow-up. There was no adjudication or audit record. And as I've mentioned, the results seem really implausible. And for various technical reasons, it looked as though this was largely the MAPEC data dressed up as a trial. So they concluded that the reported data from the Hygeia trial must be disregarded and blood pressure medication should not be routinely dosed at bedtime. Certainly the Hygeia trial was, what can I say, unreliable evidence. Last year, the International Society of Hypertension, along with the World Hypertension League and the European Society of Hypertension, did a summary of the data evaluating whether we should give the tablets at night. And they said there are 3 ongoing, well-designed, prospective randomized trials expected to provide high-quality data on the efficacy and safety of evening or bedtime versus morning dose drug dosing. But until the information is available, preferred use of bedtime drug dosing of antihypertensive drugs should not be routinely recommended in clinical practice. In other words, supporting the idea that we should not pay any attention to the Hygeia trial. And then one of those 3 properly conducted large trials, the TIME trial, and this is where I was the independent chairman of the scientific committee. They were published last year in the TIME trial. This was a large trial, over 21,000 adults, properly conducted, randomized, parallel study of adults who are on at least 1 blood pressure lowering agent, and they were asked to take their morning doses in the morning, 6 to 10 a.m., or the evening, 8 p.m. to midnight. Primary endpoint was cardiovascular death and non-fatal MI and non-fatal stroke. And the patients, 21,000 of them, were properly followed up for 5.2 years. And here you see the endpoints on the left-hand side, primary composite endpoints, and you see the event rates for evening dose and morning dose, the hazard ratio, and the p-value. And without going into it, primary composite, myocardial infarctions, strokes, vascular deaths, and all-cause death were not different between the 2 groups, whether you took your tablets in the morning or the evening. As you see, the hazard ratios were very close to 1, and there was no statistical difference between those who were given their tablets in the morning and those who took it at night. This was a properly conducted trial. The interpretation of this in the publication in the Lancet was that the evening doses of usual antihypertensive medication was not different from morning doses in terms of major cardiovascular outcomes. So I concluded that patients can be advised that they can take their regular antihypertensive medications at a convenient time that minimized any undesirable effects. I would add to that that I think the patient should take the tablets when they are most likely to take them. So it optimizes adherence. That's the best time, at least as far as the information goes at the moment. 3 possible caveats where nocturnal dosing might be okay, but we don't know. Well, if you're going to use short-acting agents, and I wouldn't recommend that ramipril as a short-acting agent, I prefer longer-acting ACE inhibitors, but if you are going to use a short-acting agent like ramipril, maybe you're better off taking it at night. For those patients who don't dip at night, maybe it's possible, particularly with a short-acting agent, that you might want to give the drug at night. And the other caveat is that the other 2 trials mentioned in the International Society survey show the other 2 trials, the BED-MED trials, are yet to be published, but they're relatively small and it's most unlikely they'll contradict the time trial results. Thank you for your attention.
Thank you, Dr. Paul. I have a question. Usually you use a combination therapy, including diuretics. Therefore, the use of antihypertensive medication at night may cause some problem.
Well, interesting, in the time trial, the quality of life issue was looked into, particularly concerns about diuretics. And that didn't seem to be a problem. There was no loss of quality of life as a result of taking the tablets. And the other thing about diuresis, I think once the patients are stable on their diuretic, once they're stable on their diuretic, the diuresis which follows the drug immediately after the drug is much less apparent and not something of concern. I don't tend to use thiazide-like thiazide diuretics. I use thiazide-like diuretics, so preferentially for my money indapamide, and that doesn't seem to give you the diuresis they're concerned about. So taking the tablets at night, whether you take it day or night, doesn't make any difference. The one tablet I do tend to give at night is amlodipine because of ankle edema. And it's not commonly known, and you probably don't believe it, but if you take amlodipine at night, you are less likely to cause ankle edema. So that's the one tablet I do take, but that also causes a natriuresis as well at night. But on the scale of things, combination therapy, whether you take your drugs in the morning or the evening, in terms of cardiovascular outcomes, it doesn't matter.
What do you mean by the night? At what time? 9?
Well, I showed you what the range was in the trial. Individuals vary when they go to bed, so you can't specify what night is in a trial. You have to give them a range, and it was 8 till midnight in that particular. Any time between 8 and midnight was night.
Neil, thank you for coming. Thank you for your presentation.
Pleasure.
Suppose I am a normotensive, but I am a non-dipper. How can I restore my normal physiology? And if I do so, is this have a good cardiovascular outcome? Can I reverse my cardio outcome scenario?
Well, that's a very good question, and the trial evidence can't inform that for the moment. But as I said, my caveat might be for non-dippers. I think it is true that non-dippers, for whatever the average 24-hour blood pressure is, do worse from a cardiovascular point of view. So you might want to focus a short-acting agent. If during the day the blood pressures are normal, you might want to focus a short-acting agent just being taken in the evening. So that would be one of the caveats that you might want to, because one can imagine that the load is a 24-hour load. There's no point in just measuring it during the daytime. And if we're not dipping, then there's a different story. One thing to my amazement was in a recent trial we did in sub-Saharan Africa, 75% of the African participants were non-dippers, 75%. So that might be an interesting subgroup to look at in subsequent studies.
Thank you, Dr. Neil. I have to close the session for the time. Thank you very much.